Good evening, friends. Welcome to the monthly meeting of Cochin Ophthalmic Club. As we all know, we have not had a regular physical monthly meeting since the month of February, but every month and practically every week we have been having webinars, routine monthly meetings, PG updates for the last few months. And continuing with the same trend, we are having an update on ocular surface diseases today. And we have none other than Dr. Srinivas K. Rao from Chennai, who is a pioneer in the field of cornea and ocular surface disorders. He is our keynote speaker today. He will also be present with us for three very interesting case presentations. One from Little Flower Hospital, Angamali, one from Giridhara Institute, Cochin, and the third from Amrita Institute of Medical Sciences. So we have three case presentations. And we have one case presentation initially, then we have the keynote address, and then we'll have the two more case presentations. And to mentor the three fellows or PGs from these institutions, we have Dr. David from LF, Dr. Vinay from Giridhar, and Dr. Anil from Amrita. So this is a scheme of things today. I welcome all of you to this meeting. I must also mention that the meeting is supported by Allergan, and so we'll get going. Vinay, can you please introduce the speakers and Dr. Srinivas K. Rao to the audience, and then we can get on with the presentation by Dr. Neena. Dr. Vinay, please.
Thank you, sir. The speakers are all trainees in various institutes. Most of them, I have never met, except Ramya, who is our PG, and I know her well. The mentors, I don't think we need any introduction to us. Okay, David has been prominent in cornea field in Kerala for quite some time. Anil, one of the pioneers in probably the second corneal surgeon. Trained corneal surgeon in Cochin. And then Dr. Srinivas K. Rao, we call him SKR sir always. He needs no introduction to anybody in Kerala. He's actually practically like a member of KSOS for long. Sir has been in Shankar Nethralaya for quite some time, and after that he has moved for some time to Hong Kong and China, and now he has his own center in Chennai. Welcome, sir, and I hope we'll have a great evening today.
Gopal, would you like to speak a few words and then we'll start? Unmute yourself.
It's always a pleasure to be in yet another Cochin Ophthalmic Club meeting, and that too, now we are doing every week, but each week followed by the other week, we are having better and better academic program. And today, just after the neuro-ophthalmologic emergencies last week, now we have a whole gamut of ocular surface, where three of our corneal surgeons, along with budding ophthalmologists, with the mentorship of Dr. SKR, will take us through this journey over the ocular surface. So over to you, the cornea team, Anil, Vinay, and David. I think the first presentation is from Little Flower Angamali, Dr. Neena Chris William. Over to you, Neena. You can share your presentation.
Good evening, everyone. I would like to thank Cochin Ophthalmic Club and Dr. David for giving me this opportunity to present in this forum. I'll be presenting the case of a 26-year-old female who works in a cement shop. She came with a presenting complaint of pain and photophobia in the right eye for the past 2 weeks. History of presenting complaint: patient had pain, redness, along with severe photophobia and sudden decrease in vision of the right eye for the past 2 weeks. This has been a chronic problem for the past 1 year, with recurrent episodes in both eyes, for which patient was using topical steroid medication. This is currently the 5th episode in this year, and prior to the onset of this episode, patient was using topical steroids. Coming to the past ocular history, 1 year back, patient gives history of a nodular lesion appearing in her right eye, which is associated with pain and photophobia. And this was followed by the development of a similar lesion in the left eye 1 month later. And she was treated with topical redness drops, after which the symptoms subsided. However, the patient was non-compliant to treatment and there was recurrence of the symptoms. There was no relevant past history, no history of any systemic illnesses like tuberculosis. Personal and family history was non-relevant. Coming to examination, general examination, patient was moderately built and nourished. There was no pallor, icterus clubbing, coronacia or edema, and there was no facial erythema or telangiectasia. And other systemic examination was within normal limits. Coming to ocular examination, visual acuity was hand movements in the right eye and 612 improving to 6.9 with pinhole in the left eye. Head posture was normal. There was no facial asymmetry. Extraocular movements were full in both eyes. And intraocular pressure was 16 millimeter mercury in the right eye and 14 millimeter mercury in the left eye using tone of pen. Coming to right eye examination, lid and adnexa, anterior blepharitis with lashes was seen. There was no evidence of any trichiasis, entropy, and ectropion, or any telangiectasia of the lid margins, or there was no evidence of any nits. Conjunctiva showed circumcorneal condition, and there was no follicles or scarring of the tarsal conjunctiva. In the cornea, there was a diffuse pannus extending from the superior and inferior limbus, progressing towards the center of the cornea. The central 4 millimeter of the cornea showed thinning with full thickness corneal infiltrate. Anterior chamber showed grade 1 cells, and posterior segment, there was no view. Coming to the left eye also had blepharitis with matted lashes, and there was a linear pannus extending from 1 o'clock to 7 o'clock position with multiple circular scars. Anterior chamber was quiet and posterior segment was within normal limits. Summarizing the case, is the case of a 26-year-old lady who came with history of pain, redness, photophobia in the right eye for the past 2 weeks. She has had recurrent episodes of the past 1 year, which was treated with steroids, and patient has had waxing and waning of symptoms. However, she was non-compliant to treatment. Visual acuity was in the right eye was hand movements, and left eye was 612 with pinhole improving to 6.9. And right eye showed squamous blepharitis with diffuse pannus, corneal thinning, and full thickness corneal infiltrate. And the left eye also had blepharitis with pannus and multiple scars. Based on our history and physical findings, we came to the provisional diagnosis of right eye corneal flictinulosis with secondary microbial keratitis and left eye corneal scarring with pannus. Investigations. Blood investigations were within normal limits. Corneal scraping, grams and KVH was negative, and culture showed no growth. Eyelash microscopy was done to rule out Demodex infection, which was absent, and B-scan of the right eye was within normal limits. We had also done a physician consultation to rule out tuberculosis. Chest X-ray was normal and MAN2 was negative. Coming to the course in the hospital, this is a picture of day 3 of presentation. We were unable to take a picture on day 1 because of severe photophobia. And since we were suspecting secondary infective keratitis, we had started the patient on topical fortified medication, that is vancomycin and amikacin, along with lubricants, cycloplegics, and tablet doxycycline. And this is the presentation on day 7. There is significant decrease in infiltrate with epithelialization. And on day 7, we had also started oral prednisolone to reduce inflammation. And after 2 weeks, the patient presented with significant scarring, reduced inflammation, and decrease in infiltrate, and patient was symptomatically much better. Thank you.
You can stop sharing your screen, Dr. Nina. Open for discussion.
Hello. Can I? Hello. I'm myself, Dr. David. In our case, there was some differences from the routine presentation. When patient presented to us, he was already on topical steroids. So that led us to a suspicion that whether it could be there could be some underlying bacterial or microbial keratitis. That's why we proceeded with a corneal scraping. The scraping was negative, but we empirically started the patient on vancomycin for gram-positive and amikacin for gram-negative coverage. And as we had expected, the lesion showed some response to the treatment. So the lesion was coming down, and once we found that the infection was getting controlled, we added oral steroids to reduce the inflammation. And the second point for which I had a doubt was that the patient was on treatment, even though patient was slightly on regular follow-up. With every episode, we were treated with topical steroids. We had given lid scrubs. With all this medication, the lesion was progressing at each visit. They started on one corner of the limbus and it had extended to the other corner of limbus. So, is there anything else which we can do to protect at least the vision in the left eye? The right eye is already affected, and patient would have a severe visual incapacitation. Is there anything which we can do in the left eye to prevent further recurrences or infection?
SKR sir, please unmute yourself.
I'm sorry.
Yeah.
Yeah, I have a similar patient like this as well. So basically, she also does not show any features of classical acne rosacea, because when you have a very bad lid, then you can see changes like this. At the very outset, just because there are PGs and there's a discussion, I just want to put up a point that this is most likely flictanular based on the history and the presentation, but I would also like to keep viral keratitis in mind. Because the pattern here is it's not just peripheral keratitis, it's migrated all across, and particularly in the left eye, you have something like a linear lesion across the cornea. So a recurrent viral keratitis, I think we keep it at the back of our mind for the differential as well. That can also present with repeated attacks and result in corneal changes such as this. And a scraping can be negative when you have some infiltrative lesions in the cornea. So we keep that in mind, although I think the chances of that are not very high in this particular instance. So in this particular instance, since you've already ruled out tuberculosis, we have been originally taught that intestinal parasites are one cause of ocular surface inflammation and flictin. So I think there's nothing wrong in getting a stool exam for parasites over ANSYS. In case there is any parasitic infestation, then we can try and treat that as well, because antigens from somewhere are often responsible for these kind of ocular surface changes. You've ruled out tuberculosis, which is the other common cause. And then if the parasites are not there, then we are left with the lid as a cause of the inflammation in the eye. So it's a staph immune keratitis. So we do our best to control the meibomian gland dysfunction and the blepharitis. And sometimes this is a very chronic, frustrating and ongoing process. It doesn't get better in the 2 or 3 weeks that we normally get these patients better with. We may have to keep them on long-term, low-dose doxycycline. Unfortunately, in India, we don't get the 20 and 40 milligram tablets. So what I've started taking to do is I take the 100 milligram tablet, not the capsule. We try and break it into 3. And so they take approximately 30 to 35 milligrams of doxycycline on a day. And this goes on for a while. And these are patients in whom we may have to keep them on some low-dose steroid for a very long period of time. We conventionally think of steroids in this context as a 2 or a 3 week process, even if you're using a loteprednol or a fluoromethalone. But here you may have to keep them on the long term. And even though your lash exam for Demodex did not show any positivity, I would think there's nothing wrong in alternating your lid scrubs and hygiene measures with a tea tree oil shampoo, because when you have this degree of blepharitis and meibomitis and this degree of ocular surface inflammation, I have often found Demodex to be a silent instigator of these changes as well. So I would think we can add the 5% tea tree oil shampoo. I don't think it's going to harm you very much. And so this is the best we can do. And then if you have access, if the lid continues to show meibomian gland dysfunction, if you have access to one of those light therapies, the IRPL or something like that, the pulse light, I think there's nothing wrong in putting her through that as well and cleaning up the glands as best as we can, apart from the massage and apart from the doxy. I think that would add another facet to helping change the quality of the oil that the glands are producing. And we try our best not to have, because like you said, if you keep having inflammation, each time you lose a bit of cornea and the left eye will lose its vision as well. So this is about what I would like to do for this patient. Keep her from having any further episodes. We're putting everything we have into the mix. And in my patient, because I've been going through this for the last 3 years now, and in desperation, I put her on Metrogel as well, a little bit of Metrogel, because the acne rosacea, it's very hard to make a diagnosis unless they have the classical findings, particularly in the dark skin people like we have. And therefore, because I've tried everything and I still keep getting problems, I put her on a short course of metronidazole as well. So that is something that maybe later we can consider.
Can I ask a question, Dr. David?
Yes.
At some point of time, is she a candidate for a keratoplasty? I mean, if things get better, or this is a contraindication?
Yeah. No, yes. Once the inflammation comes down, and there is no recurrences for a significant period of time, we can plan for a, because it mainly affects the anterior surface of the anterior portion of the cornea. The deeper layers might be uninvolved. So a laminar keratoplasty might be an option if there is a significant decrease in vision. And if there is an irregular astigmatism and if patient improves in vision with dual contact lenses, that's another option which we can have.
Thank you.
Usually, once you get rid of the inflammation, the pannus does tend to regress considerably. Although in the right eye, you've had a bit of an infection with stromal loss, so that might result in some scarring. But the pannus alone, if it is there, usually the regression of the vessels is quite significant. And like you mentioned, the rigid contact lens often allows you to recover useful vision. It may not be perfect vision, but it allows you to recover useful vision. And luckily, in this lady, you don't have a significant limbal stem damage. I think it's reasonably localized. So if you can't improve her with a contact lens, then I guess a lamellar keratoplasty would be a reasonable option for her as well.
Sir, I have a question for you, Srinivas sir.
Yes.
What is your experience regarding the intense pulse light regime or the IRPF, regulated pulse light?
I don't have all that much experience. We've probably done about 60 patients so far in the last maybe 8 to 9 months that I've had it. I would think about 70 to 80% of people are benefited both from my assessment of the ocular surface and the lid and from the patient's perception. The longest follow-up we've had, like I told you, is about 6 to 8 months. So far, we've not had to retreat any of these people. In about 20% of people out of these 50 or 60 odd that I've done, the response is there, but I wouldn't say it's a complete response. We still have to put them on some lid massage and all that. But the other 3/4 have been considerably improved. And some of these people have been with me for about 4 or 5 years with multiple recurrences before we access the IRPL. So I think in some way it works, although I don't think we are able to clearly understand exactly how it helps. But if you believe the theory that you're doing some deep nerve stimulation and therefore altering the meibomian gland quality of secretion, it does seem to work. Although you must remember that this is not in lieu of the LipiFlow, which does the massage and expresses it. So this does not do any massage or doesn't express anything. So even if you do this, you will have to put them on some kind of a physical massage, or you add something like a LipiFlow if you have that as well. So the two kind of independent things. One gets rid of the secretions, the other one changes the quality of the secretions. So sometimes you may have to put both together as well. They're not mutually exclusive.
So in your patients, sir, you do both together, I mean the massage and the IRPL together.
Yes, so basically the IRPL is done day 1. We do one more session 2 weeks later, and we do a third session 4 weeks after that. So it's a 6-week course. So for the first 2 weeks when we start this, we put them on the routine physical therapy as well as some steroids because we are expressing a lot of this inflammatory stuff out. So this goes on for 2 weeks, and after that they stay on just teardrops. And the third session is done, and then we assess and then decide what to do. In some of these people with very bad eyelids, what I've taken to doing now is after I have everything under control, instead of just letting them go and then having them come back 3 months later with a major flare-up, I put them on the lid massage with a little azithromycin ointment and some tears and a mild steroid once a day or something for the first 7 days of every month for the next 3 months. So we're not doing this ongoing on and on and on, but I'm not just stopping it and then letting everything collect and then they come back 3 months later with another frank episode. So in the more severe versions, I will clean it up and then I will ask them for the next 3 months to do something for the first week of each month. And I find that that helps me as well. So it keeps things under control a little better.
Because the company person, we had a demo of this in our hospital. The company person claims that you don't need to do any massage, but that's what they claim.
Because see, we are doing this for people who have the worst. We're not going to put everybody who walks in with mild disease on this, unlike what they want you to do. They want you to put it for every mild disease. We usually don't do that. There's a cost involved and all that. So these are people who have the more severe versions of the meibomian gland disease. And if you think about this basically does some heating, it does some nerve stimulation, and that's pretty much it. So we can say that we're closing the vessels, we're reducing the inflammation. But what about all the oil that is sequestered in the gland? That needs to come out, isn't it? Otherwise, it will keep coming out while this process. So to me, logically, it seems like I would like to do this. And this is what I've been doing ever since I've had it right from the beginning. And like I said, with this approach, about 3/4 of my patients seem to have gotten better, and they feel a lot better as well. And some of these are the worst MGDs that I've had.
Thank you.
David, can I ask one question? Have you done this one PCR for HSV DNA along in the scraping that we did?
No, sir. PCR was not done.
Okay, okay. No.
Adult inclusion conjunctivitis is another thing that we do keep in mind when we have these chronic kind of pictures in the eye, but that generally tends to be more of a unilateral picture, and you see more of a 360-degree limbal inflammation and vascularization, unlike what you showed, where it's kind of specific to the superior and inferior and just came and met across the center of the cornea. It was less in the left and more in the right eye, but the horizontal meridian of the limbus seemed to be a little less inflamed. So that is a third distant possibility that I would keep in mind, but at this point, I don't think that's really, in this particular case, important. Anyway, if you're going to give us a macrolide antibiotic, which you will for your lid margin disease, then that would get covered as well.
Can we go on to the keynote address by Dr. SKR, sir? Vinay, can we go on?
Yes, sir.
Yeah. So Dr. Srinivas K. Rao is speaking on algorithmic determination of conditions affecting the ocular surface. Dr. SKR, please.
Hi. I hope you're seeing a blank screen, a white screen.
Yes.
So that's the first slide. Okay, good. So thanks again for the invitation, Sai and the rest of the team at the COC. Happy to be part of this one more time. And let me start by wishing all of you very good health in these particularly difficult and challenging times that we are facing. So as I was just telling them before we started, a submicron particle has the most evolved mammal on this planet on the run, and we are all in hiding from this particular thing. And after all the technology that we have developed in the last century, finally a handkerchief over the nose and the mouth seems to be what is protecting us. So that's the way everything has come a full circle. So Sai wanted me to speak about something about the ocular surface today. So it was nice because this is something that's very dear to my heart. The ocular surface, after 30 years of doing this, still proves to be a challenge. It provides all kinds of various manifestations. And as we just saw in the previous case, even a typical particular condition that we categorize can present in its varied forms. What I wanted to share with you today is basically an approach. It's not really a kind of a conclusive kind of a talk. It's just an approach. I just want you to think about what I'm trying to say and see if you can, look at your patients slightly differently after the session that we're doing today, and that might help you. So the ocular surface, if you think about it, occupies a very, very small area of the real estate in the human body. So this is about actually 2.2 square centimeters if you go by measurements. But this is not a constant value. If you're looking down, when you're reading a book or something, this can go down to 1.2 square centimeters. And if you're looking up at something, then it can increase to 3 square centimeters. So it is a variable area of the ocular surface that we're dealing with. Now, one of the things that keeps this ocular surface very happy, and if it is happy, do you have comfort and you also have good vision, is the tears. So basically, there's a very small amount of tears that is present on the ocular surface. This is about 6.5 microliters. And this needs to be spread across the entire surface, even though it collects mostly in the lake in the bottom and the near lid. This spreading action is done by the lid. So unless the tears are present in adequate volume, and unless they are spread evenly across the surface repeatedly by the blinking action, and unless they leave the ocular surface on a regular basis, you do not have comfort on the ocular surface. Now, this blink rate that we're talking about is normally at an average of about 16 to 18 times a minute, but this can change. Like right now, when I'm doing this talk and I'm trying to stare at the screen and make sure I don't miss anything, it can reduce considerably to even 1/4 the rate to about 4.5 times a minute. Or if I'm very excited and trying to make my point very forcibly, or I'm arguing with somebody who banged my car this morning, then I'm very excited and I blink a lot more. I blink about double the time, about 30 times a minute. And this produces a lot of microtrauma. Every time you blink, the lid contacts the ocular surface. There's a little microtrauma. So if you're blinking excessively as well, it may not be particularly good for you. Now, the tears are not a static process, it's a dynamic process. Once they are on the surface, evaporation keeps taking it off the surface. And this again is controlled by various things. The normal rate is about 7.6 grams per solute. That's the rate at which it evaporates from the surface. But this can be determined by the temperature in your ambient environment, by the humidity, and by the wind flow. So basically, if you're outdoors working on a building, as a mason building a building, and there's a lot of wind and breeze and dust blowing, you'll have a problem. Or like today, if most of us are sitting in an air-conditioned room and by mistake the AC is actually blowing across your face, then again you will have a problem. So the ocular surface and its tears are quite dynamic. Now, all of this, the tears, the lid blinking, everything is designed to keep one structure happy. That is the cornea and its surface epithelium. Only if this structure is happy will we have the comfort, because the cornea is one of the most richly innervated structures in the human body. That is why a lot of our people with ocular surface disease come to us with such significant problems of the surface. And only if the cornea is healthy and the epithelium is happy will you have clear vision without any fluctuations. To keep this corneal epithelium intact, we have the limbus, which is surrounding the cornea, which produces the cells that come into the cornea. And to keep the limbus active, you have the conjunctiva with its various goblet cells and the mucus secreting cells. So there are a number of structures that go on to keep everything in a normal functioning state in the ocular surface. Now, there are a lot of deleterious influences which can work on this. We're living in conditions of increasing pollution, so this impacts the ocular surface. A lot of us are on oral medications even in the ages of early 40 and mid 40s. So these have impacts on the ocular surface, and a number of systemic diseases, and the mixed connective tissue diseases are the one classic example. So if you have something like that, then this systemic process has an impact on the ocular surface as well. So this cartoon was used basically to tell you that this is a fairly complex thing that we're dealing with. We just use two words, the ocular surface, to describe it, but there's a lot of things that are going on both on and underneath the surface to keep things well. And therefore, what we're really talking about is the ocular surface homeostasis. So what we should be looking at is anything that affects the loss of this ocular surface homeostasis when somebody comes to us with symptoms pertaining to the ocular surface itself. A common misconception, unfortunately, even today, is that dry eye disease equals ocular surface disease. Now, dry eye disease is important. I'm not saying it's not. A lot of these problems are associated with tear dysfunction, but it is not the only thing that is happening. So dry eye disease is a common problem, but there are often other causes when we talk about ocular surface disease. So the next 25 minutes that I've been given is to basically try and give you an idea of what are these other causes that we're talking about and how do we approach those. So unless we get a handle on those, it is unlikely that we will be able to treat our patients well. So when you're managing this loss of ocular surface homeostasis, just giving a tear substitute alone is seldom enough. In fact, literature tells you that you will be wrong 2/3 of the time if you just gave tear substitutes to everybody who came to you with symptoms of a distressed ocular surface. So what we should really be doing is to have a knowledge of and an ability to detect these other causes that are working on the surface. So I keep saying these other causes. So what exactly are we talking about? Now, this is a slide that I like very much. It looks very complicated, looks very scary, but it is not. Each of these conditions is what we are normally dealing with. None of them are rare or exotic conditions. It's just that we need to have them in mind when we're talking in the context of an ocular surface disease, which is the challenge, which is what we must train ourselves to do. So I'm just going to start from this picture on the top left and work my way down. So this is adenoviral conjunctivitis. So we know that before, during, and after adenoviral conjunctivitis, you can have significant changes to the ocular surface and to the tear function in many of these patients. So keep that in mind. This is allergic conjunctivitis. You can see that typical pale ballooning conjunctiva. So this is something that can happen. Now, these are people who have accommodation and convergence issues. So this is not uncommon today when most of us are working from home and spending 8, 10, 12 hours in front of a computer. So if you have accommodation and convergence, apart from the brow ache and the tiredness, they will come to you with some ocular surface symptoms as well. And if we are not aware of this, or if we're not looking into this, we may just be giving them tears, and missing the other problem, which is causing all of this. If you have changes which are limited to the medial canthal region, a lot of congestion and discharge with the rest of the eye looking all right, if you keep canaliculitis in mind, it's not all that uncommon. And basically, this is about thyroid eye disease. You can see the congestion sitting there right at the insertion of the muscles. So sometimes this can be there. And then you can have people with contact lens use, having problems from the lenses or from the preservatives in the contact lens solutions, or from misuse, from extra use of lenses which are meant to be thrown away after a month. They keep using it for 2-3 months. So contact lens, another problem. The lid, I told you, must blink very often. So lag ophthalmos like this, very easy to pick up. Sometimes it's more subtle and sometimes it's nocturnal. And these are things you keep in mind. Filaments on the corneal surface, conjunctival concretions on the palpebral surface, aqueous tear deficiencies with this kind of corneal staining, the environmental conditions, like we mentioned, outdoor workers, indoor workers, subject to different kinds. So most often low humidity environments like air conditioning, particularly if it's blowing across their eye. If it's blowing from the right side, the right eye may be asymmetrically more affected. A lot of us are on medications for our eye problems. So you have preservatives in most of these. You can have floppy eyelid syndrome with a loose lid causing ocular surface problems. HIV causes dry eye, can cause surface changes like a kaposis in this case. You can have a eversion of the punctum basically because of a lax lid in the elderly. This is very common, often missed. This is the lid viper epitheliopathy. If you flip the upper lid and stain it with lissamine, you can see this mucus pad, 2 to 3 millimeters, just at the border of the upper eyelid and the palpebral surface staining. This causes a lot of burning because of the frictional trauma due to the microtrauma when they blink. This little fold of conjunctiva here is called the lid parallel conjunctival fold, goes on to conjunctivochalasis, again in the elderly, again a cause of significant ocular surface problems. Lid margins, you can have parasites, she mentioned nits, you can have that from the thyris. You can have posterior lid margin disease, the meibomian gland disease with the froth here. We can have anterior blepharitis, which is staphylococcal or seborrheic. You can have limbal changes. You can have basically changes due to medicamentosa. You can have the morning eye congestion syndrome, the mucus fishing syndrome, neurotrophy on the surface. This kind of vascularization is a carotid cavernous fistula, which you cannot afford to miss, even though they come to you with what looks like ocular surface problems. Basement membrane changes and recurrent corneal erosions. Muhammad Ali with this Parkinsonism, where he doesn't blink at all. So that causes ocular surface changes. People with Stevens and OCP who develop keratinization of their lid margins, acne rosacea, which we briefly talked about, superior limbic keratoconjunctivitis, staph immune keratitis, the version of most severe version of which we saw, limbal changes, corneal contour changes due to edema, oral medications, and also an excess of tears. So basically, when you have tear stasis due to whatever reason, can also cause problems. So it's not just the lack of tears. So none of these are rare conditions. None of these are difficult to diagnose. I think the trick is basically to keep these in mind and have a plan when examining your patients, so that if you keep these in mind, then most often you'll be able to pick them up. So what are we talking about? So when you look at the patient itself, you can get a lot of clues that can impact the ocular surface. So when he walks into the room, if you look at the face, you get a lot of clues. We talked about rosacea in the previous example. So you'll see the typical acne, you'll see the rhinophyma on the nose. If he has SLE, you may be lucky enough to see a butterfly rash if it's a fast-skinned individual. When they give you their prescription to look at whatever they've been treated with, their hands, you have a chance to look at them. You can have joint deformities if they have rheumatoid arthritis or psoriasis. There may be tremors. If they have a pill rolling tremor, it's Parkinson's. If they have a finer tremor, it could be a thyroid disease. You look at the skin of the face, there may be dermatitis, atopic changes may be present, or it may be a stretched and shiny skin, which is scleroderma. All of these affect the ocular surface. So if you look at the scalp, and if you're wearing a black shirt like me and you're seeing white flakes, basically that's dandruff on the scalp, and lucky you might have the same thing on the lid margin. If you look at the ears, there may be deformity due to gout or cartilaginous changes in polychondritis. Look at the glands. You may have a swelling in Sjogren's, or you may have lymph nodes, which may suggest a tuberculosis or a perinodes, which are all ocular surface inflammatory conditions. Look at the lids grossly. When the patient's sitting and talking to you, the blink rate itself. If you have a dry eye, he may not be able to keep the eye open. He'll try and keep blinking more often because of the rapidly evaporating tear film. On the other hand, a Parkinson's patient may not blink at all during the entire course of the examination for the next 2-3 minutes. The blink profile, if you think it's incomplete, then you suspect lag ophthalmos. You ask about nocturnal lag ophthalmos, and people who have a lot of puffiness of the lids have a very slow blink rate. The reason is the weight of the skin folds causes them a lot of difficulty when they open, so they're scared to blink. They try and keep the eye open because they don't want to blink and make that effort to open it again, because that extra weight puts the levator on stress. The lid structure, you may have scarring either from diseases like trachoma or trauma, or if you've had past HSV or HZO, which we'll talk about neurotrophy as well. You look at the lid position. A thyroid patient will have an elevated lid with an upper limbal show, or you may have a drooping lid, either from an aponeurotic ptosis or from a myasthenia, particularly if it's variable during the day. And when you're handling the lid, if you just pull it and let go, if it flaps back nicely, then it's a nice normal tension in the lid. But if it's a very lax lid, it'll take a long time to go back, which means it's sagging, and that affects the tear excretion from the surface. Or there may be a floppy eyelid. Just hold the upper lid lashes and pull the lid up, and you'll find it flipping instantly. And again, if there's any entropion or ectropion, you can have problems. Then when we actually look at the patient on the slit lamp, you look at how much of tearing there is. The moment you put them on the slit lamp, if there's an excess of tearing, there's either a tear stasis, an NLD block, or an infective process. If he's very photosensitive to light, there may be some infection, there may be severe dry eye, or there may be some inflammation on the ocular surface. Look at the tear meniscus along the lower. Normally, it's about 1 millimeter. When you look at enough normal people, then you'll understand whether it's lower or higher. So that gives you a clue. And then you look at the quality of the tear film on the ocular surface. You may see a lot of mucus strands floating in it. Sometimes you may see the oily interference fringes if there's a lot of meibomian dysfunction. There may be misdirected lashes, and we spoke about blepharitis. So this can either be in the anterior part of the lid, where it can be staphylococcus seborrheic, or they may be in the posterior part of the lid from the meibomian glands. So you can have meibomian gland dysfunction. You also try and look at the punctum in the lids. Basically, make sure the opening is normal. If it is tightly stenosed, then it will not allow the tears to go out. But if it's widely open, inflamed, and patulous, it may indicate a canaliculitis. The ocular surface, we look at the different regions because inflammation in different parts has different connotations. In the medial canthus, you can either see keratinization, which is an early sign in OCT, or you may see discharge localized to that region, as I mentioned, in canaliculitis. On the bulbar conjunctiva, you look at the surface, both the contour and the inflammation, and we'll talk about these conditions subsequently. Look at the corneal surface. If it's dry and lusterless, you have a tear problem, or sometimes you may see basement membrane changes, which may be aggravating all this. And in the conjunctiva, in the upper lid and the lower lid and the phonesis, we're essentially looking for follicles, we're looking for papillae, and we're looking for scarring. So each of these will have different implications, as I shall talk about in the last slide. Also look at the other structures. If you have underlying connective tissue problems systemically, sometimes you may have scleral and episcleral inflammation or thinning. Look at the limbus. Basically, there may be chronic allergies or superior limbic keratoconjunctivitis causing changes, or there may be scarring resulting in limbal stem cell deficiency. We look into the eye as well, looking for inflammation inside the eye in the form of uveitis or infections, because sometimes these people present with redness, and in a busy clinic casual exam, you may miss that circumcorneal congestion and just treat it like a ocular surface inflammation. In the iris, you may have atrophy from past herpes zoster or nodules if you have an ongoing granulomatous inflammation like tuberculosis or sarcoid. And in the lens, if you have opacities, this may either be from the disease like atopic keratoconjunctivitis, which causes a shield cataract, or from the long-term use of steroids for treating the condition itself. And you have to look at the other things in the eye as well, because in the retina, sometimes there may be vasculitis in HIV and other connective tissue diseases. Look at the pupil and the IOP, because in HZO and glaucoma, you can have that. And don't forget in somebody with a very congested eye to check ocular movements as well, because very rarely significant serious problems in the orbit like pseudotumor and cavernous sinus present to us as ocular surface inflammation. And don't forget orthoptics, because of these people who sit and work on their computers a long time, do assess convergence and accommodation and pay some attention to the environment that these people are sitting in. So these are the various things that we look at, both systemically and from the eye perspective. You may not have to look at everything in everybody, but if you have an idea of this, then basically when you're examining the patient, you're less likely to miss some important findings. Once you've done these two, once you've had a good idea of the diseases, once you've had a good idea of the findings on the eye and the systemic process, then you can think about what tests that you want to do. We obviously know we can do a Schirmer, a BUT, and check the NLD. You can check the lids. Basically, you can check for laxity. You can do your thyroid tests. You can do the floppy eyelid test and do an ice pack if you suspect myasthenia. Look at the meibomian glands. All we have to do is to put our thumb against the middle half of the lower eyelid and push firmly against the lid. The thumb usually covers about 4 to 5 of these meibomian gland openings. So when we push, we want to see how many of these glands actually express anything. If nothing is expressing, that's meibomian sicca. So if they do express, we want to see the type of secretion that comes out and the amount of secretion that comes out. If you have excessive secretion, that's seborrhea. And if you push and you get a little paste-like tube coming out, that's meibomitis or inflammation. Like I said, we look at the lower fornix. You can check orthoptics. You can check for the work environment. And occasionally we may need some microbiology if you're suspecting some infections. You may need blood work if you're suspecting connective tissue diseases, thyroid tests if you're thinking of a dysthyroid state, radiology if you're thinking of orbital changes, and a biopsy if you have a surface change that suggests some kind of a tumorous process. So there are various tests that we can do to do all this as well. Now, this ocular surface evaluation itself is becoming increasingly complex. So basically, the DUCE-2, which is the most recent recommendation as far as the dry eye changes are concerned, would suggest that you do an NIBUT because it's more physiological than a BUT. It suggests that you measure the tear meniscus height because they believe that that's a more valid measurement of the tear function. And they want you to look at the lipid on the ocular surface doing some kind of an interferometry to see whether you have enough of an oily film on the ocular surface. And then they want you to do a mabography to look at the state of the meibomian glands in the lid and some kind of an assessment for the ocular surface inflammation. You can do an MMP9 assessment. There are other tests that are coming up, but you can also look at redness on the ocular surface as a surrogate marker for inflammation on the ocular surface. Unfortunately, doing all of these tests requires a separate instrument. One of these is this. It does all of this and it gives you a nice report where it puts everything in one compact sheet. And those basically what it's trying to show here is this is a scale of normalcy to abnormalcy. And this arrow indicates what is the position of this particular patient. So it's measuring the area of the meibomian gland, the meibomian glands. And if the area is normal, it will put it in the green. If you find there's a lot of gland dropout, atrophy, and loss, and if the amount of area that's calculated seems a lot less than normal, this arrow will be in the red. And if it's somewhere in the borderline state, it will be in the yellow. So for each of these tests, the NIBUT, whatever, it gives you that kind of a reading. So it gives you a composite thing. The problem with this is it is a little expensive, both to buy and for the patient each time you do this. So what we are doing is we're using the BUT as a surrogate marker. We're using the Schirmer. We don't really have a test that will mimic this, the interferometry, but you can look at the meibomian glands using your autorefractor because it is an infrared tool. You can see the lid glands exactly like this if you're using that with a +4 lens. And we're using the redness score on the ocular surface as a marker for inflammation. So you can do this clinically as well. You don't necessarily have to go about buying these costly instruments. So the clinical tests, I just wanted to make one point. We're going to go through each of these in the last slide. So when you're doing the fluorescein, you're looking at the cornea. When you're doing the racemine green or the rose bengal, you're looking at the conjunctiva. So what you want to look for is the presence of staining. You want to look at the extent of staining. And most important, look at the location of staining. Superior corneal staining versus inferior, total corneal staining versus interpalpebral. Each of these has a meaning. And you want to also finally correlate the amount of corneal stain with fluorescein vis-a-vis the lissamine stain on the conjunctiva. In a dry eye, where the entire surface is affected, usually both will be equally seen. You will see corneal staining, you will also see significant conjunctival staining. Sometimes you may see extensive corneal staining, but not enough lissamine green staining or no lissamine green staining on the conjunctiva. This usually indicates a medicamentosa state because the corneal epithelium is the more delicate epithelium. So when you're putting a toxic medicine for 3 or 4 weeks, like a NSAID or something like that, the corneal epithelium will first show the changes, but if you treat it long enough, the conjunctiva will also show. But in the early stages, you'll see a lot of corneal staining, not enough conjunctival staining, and this mismatch or correlation is also important. So if you want to have an eye that looks like this, very happy, shiny, and a nice, brilliant reflex from the slit lamp on the cornea, and basically if this eye goes into some problem, what we want to think about is the various conditions that I showed you in that composite slide. We want to look at the various system and eye changes that we saw in the next set of slides. We want to do some tests for the ocular surface that I showed you. And finally, in order to put all this together, you might want to have some kind of an algorithmic approach to your diagnosis. So this is what has worked for me over the last 2 to 3 decades that I've been doing this. So I go through this process, and finally in the mind, basically there is some kind of an algorithm that you run through. And this will help you not miss any of these findings. So you don't necessarily have to use the particular algorithm that I'm going to share with you. You can come up with your own, but this systematic approach is needed so that you can figure out what else is happening on the ocular surface apart from the tear deficiency, so you can treat these patients well. And so this is what I wanted to term as an algorithmic determination of conditions affecting the ocular surface. Now, this is the next composite set of slides that some of you may have seen before. This is something that I've been working on for the last decade or so, and this is the final iteration that works. So what I'm trying to show you is how to put all of these things that we just saw in the last 25 minutes or so. We saw conditions, we saw various signs and symptoms that can be there, and we saw some tests and their results. So we want to see how we can put all these together. So essentially, if you basically looking at these people, the first thing to ask them is, do they have constant symptoms? If somebody says, look, I mean, last week I had irritation for about 10 minutes, then it got better, and then, I mean, happened again once month ago. Otherwise, I'm largely all right. So the symptoms are not constant. And when I do my basic exam, if I don't find any findings, then all you need to do is to give this guy a tear substitute. And he's in that 1/3 of patients who will do well with just tear substitutes. On the other hand, if the patient says that I have constant symptoms, then we have to start somewhere to find out what is happening on this guy's surface. So one of the ways in which you can do that is to first look at itching. If he says itching is the predominant sign, then you look for the pigment sign. The pigment sign is basically something that we described about 10 to 15 years ago. If you see children with vernal the next time, and you look closely on the ocular surface, and you look at the triangle formed with the base at the limbus and the apex towards the canthus, both the medial and the lateral side, you will see a lot of pigment dispersion on the surface, brown to black pigment, which has its base at the limbus and then spreads out gradually towards the canthus. This is a very sensitive sign of vernal in pigmented eyes like ours. So if you see the pigment sign and he has itching as his predominant symptom, we're dealing with vernal, and that goes in one path. If he has itching, but you don't see the pigment sign, you can ask for the presence of other allergy, and often they will have skin allergies. And this is atopic keratoconjunctivitis. And because in atopy, we don't see the pigment sign for some reason. They have itching, they have the other features, but they won't find the pigment sign. If you don't have itching as the main sign, then the next thing that you can ask is, does he have redness in the eye? This is another common symptom. So how do we try and determine what are the various factors that can cause this redness? If he says the redness is present, you ask him, is it diffuse when you see as well, or is it localized? If the redness is diffuse and is associated with tenderness, scleritis is a possibility. If it is diffuse redness associated with conjunctival edema, particularly pale edema of the slide that I showed you in the earlier slide, it is acute allergy. Congestion with discharge is often infective. Congestion with watering is due to tear stasis. The tear stasis collects all the inflammatory material on the surface. It's not leaving the eye. Therefore, there is inflammation and congestion. And if you have congestion with extraocular movement restriction as well, which is why you should never miss testing that, then sometimes there can be something more sinister happening, like a pseudotumor or a cavernous sinus, which is the cause of this. So when you have diffuse redness, based on what are the other features that you see, we can have some idea as to what is going on. If the redness is localized, then important is to consider whether it is bulbar conjunctival redness or palpebral conjunctival redness. So if it is bulbar and if it is uniform, then something as simple as a subconjunctival hemorrhage. A localized bulbar congestion with some mass lesion could be a tumor like an OSSN. If there are a lot of vascular changes with this localized area of congestion, think in terms of an episcleritis or scleritis. And if this area is also showing some ulceration, then it could be a flictenule or a trauma. And if the vessels are localized but corkscrew-wise radially distributed, that could be a CCF. These are the associated features of this localized bulbar conjunctival redness. The next thing is to look at the distribution of the bulbar redness. If it is circumcorneal, then it's an iritis or a keratitis or some limbal papillae like in a severe vernal. If it is limited to the upper half of the bulbar conjunctiva, think in terms of a disease like superior limbic keratoconjunctivitis. If it's in the lower half, it's often due to the medication that they are putting, because most people tend to pull their lower lid down and put the drop. So it touches the lower fornix first and the lower conjunctiva first. So these people will typically have congestion. If you draw a line between the medial and lateral canthus, most of the changes will be below the line. If you lift the upper lid and look, the conjunctiva there will be nice and white. If it's at the muscle insertions, it's due to a dysthyroid process. If it is in the nasal bulbar conjunctiva alone, it is canaliculitis. And if it's in the temporal bulbar conjunctival predominantly, it's a moraxella angular conjunctivitis, typically in the elderly with a little froth that you will classically see. So based on the location of the bulbar conjunctival congestion and the associated features, we can try and figure out something about the condition that's happening. If it is localized palpebral redness, then like I said, we have to think in terms of follicles, papillae, and scarring. And when you look at the upper eyelid, follicles often are chlamydial or viral. papillae, or of course allergic or superior limbic keratoconjunctivitis, and scarring indicates trachoma. The same thing in the lower fornix. If it is follicles, it's either viral or medicamentosa. If it is papillae, it is atopic keratoconjunctivitis, because unlike vernal, which affects typically the upper lid, atopy will affect both the lids. And if there is scarring in the lower fornix, it is OCP. So this way, again, we can have some idea as to what condition we are facing. If the condition is associated with a lot of burning and grittiness, and if these are the main symptoms the patient expresses, then you ask him whether there is any discharge. And if this discharge is mostly in the morning, this is due to something called the morning eye congestion syndrome, which is from the eyelids typically, either a canaliculitis or a meibomian gland disease, because all the muck from these inflammatory processes tends to collect in the lid when he sleeps. And when he wakes up in the morning, there's a lot of it floating around. If the discharge is constant, then there may be some infection, or he may be in the habit of mucus fishing, taking the mucus out all the time with his finger or handkerchief, setting up a cycle that causes it to be constant. If it's worse in the evening, it's due to aqueous tear deficiency, because most people wake up with a somewhat healthy tear film, and as the day progresses, the extensive drying that goes on makes them worse. And you also ask about the burning and grittiness and their response to the medications. Most of these people have seen other doctors before they come to you. If they've used artificial tears and they say, yeah, it helps me if I use it 4 or 6 times, if I stop it, I get worse, then it's a dysfunctional tear syndrome. But if he says, I've been using the drops 8 times a day, the tear drops are good quality one, I have no relief at all, the burning is not going away, think in terms of superior limbic keratoconjunctivitis or a lid viper epitheliopathy. If the steroids have allowed a response, it's some kind of an allergic or immune process. But if he says that each time the doctor changed my medicine, I actually kept getting worse, it's toxicity due to the medication. If the burning and grittiness is associated with watering, you check for the lid laxity with the lid test that we did. If the lids are lax and there is a lot of watering along with the burning and irritation, that's tear stasis. But if the lids are normal, but every time he blinks, he says, I have burning, irritation, pinching, and I have watering, it could be conjunctivochalasis. If this is associated with broache and difficulty in reading, if it happens after a while, it may be due to an aponeurotic ptosis. He's finding it hard to keep the eyes open. But if it is constant, there may be an orthooptics problem. Check his accommodation and convergence. And if it's abnormal, you can treat it. But if that is also normal, then you look at the work environment and the humidity of the room that he works in. And if it's worse, typically in the evening, he says, mostly by the evening I'm gone, then you think in terms of myasthenia. If irritation is the most common symptom that he's complaining of, you look at the onset of the irritation. If it is sudden, then obviously if there's a trauma, there would be a foreign body often hidden in the subtarsal sulcus in the upper eyelid. If there is no trauma, sometimes there's a lash that's broken and gone in and you can pick it up. If it is chronic irritation, if it happens on and off, think in terms of concretions which come and go. If it's constant, it could be some suture that we put at the time of some cataract surgery long ago that we forgot about that is sitting there. It could be a large bleb in the conjunctiva from trap surgery or a lid viper epitheliopathy. The irritation, the next thing you also want to ask is the diurnal change that happens. If it's worse in the morning, look for the lid laxity. If he has a lax lid, it could be a nocturnal lag ophthalmos or a floppy eyelid. But if the lids are normal and the irritation is worse in the morning, look at your tears. If the tears are also normal, it is typically a recurrent corneal erosion. They wake up with the lids causing the epithelial damage and pain. If the tears are decreased, then it's a severe dysfunctional tear syndrome. If it's worse in the evening, then basically it could be lid margin disease, whichever kind we talked about, or it could be decreased in the tears, which could be aqueous, mucus, or lipid, which your tests will pick up, and then you can try and manage. If you've gone through this whole exercise and everything seems to be negative as far as these are concerned, then you think about the other diagnosis on the first line. Think about contact lens use, think about acne rosacea, think about limbal stem cell deficiency and these other sinister things like a cavernous sinus, a tumor masquerade like a sebaceous gland tumor, a neurotrophy, a HIV, glaucoma and its medications, Parkinsonism. And only if you've ruled out all of these and everything is negative that you finally think it's psychological. Patients complaining bitterly, you're not finding anything, all of this entire algorithm has been gone through. Then finally, we think in terms of a psychological disturbance, which is causing a lot of problems for the patient. So basically, like I told you, this was not a talk that tries to give you any kind of major take home. I just wanted to give you an approach. So when we see ocular surface disease, I just wanted to tell you that I don't want people to think about dry eye alone as the major cause or the only cause. There are multiple other things that are happening on the ocular surface. So if you keep in mind the various conditions, the various signs and symptoms that you can see both generally and in the eye, the tests that you can do, and then put all of these together in some kind of a logical flow that this happens, then you are less likely to miss problems that are happening on the ocular surface. And this slide, if anybody wants it to be shared, I can send a PDF of the slide to Sai later, and then he can send it out in case anybody is interested. This is something that helps me a lot. So if you want to use it, please go ahead. Thank you. I'm going to stop chatting now.
Thank you, sir. Quite interesting and exhaustive talk. Any questions from anybody?
This was something like going through a textbook on ocular surface disorders. Fantastic.
I hope it was not an exhausting talk.
No,
exhaustive is okay.
Exhaustive, not exhausting. Now you have no. I'm just going to ask you a small question. The answer may not be in a single sentence, but to the general ophthalmologist, now we have you have said that only 1/3 of them are really the ones that can be routinely treated by a lubricant, and in 2/3 there will be other causes. Now, what is the position of each of the lubricant? Now, you have a plethora of lubricants. You have CMC, you have various percentages of CMC and sodium hyaluronate, various combinations of glycerin, this and that. If you can, in 1 or 2 sentences, if you can say which is the most ideal for which sort of ocular surface disease?
Basically, for me, what I try and do, I keep 3 things as my go-to drugs. I'll just share with you the rationale without mentioning any brand. I go to CMC the most. I don't use Cipromelos and all so much anymore because I started off with CMC. I'm quite comfortable with it. So CMC is my basic go-to drug as far as these are concerned. Between 0.5% and 1%, if the condition is mild, I give them 0.5% because the CMC is quite thick. It does tend to blur vision a bit. So if you're using the 1%, it causes a lot of blurring. And so somebody with a mild disease may not like it so much. But if they have a severe disease where their comfort is more important and vision's already not particularly good, then you can use 1%. They will tolerate the blur to some extent and they get more prolonged relief. So CMC is my go-to drug. The other drug that I use is hyaluronate. Hyaluronate I use when I see a lot of epithelial damage because hyaluronate has some epithelial healing properties. But I would not use hyaluronate as my only drug. For instance, I would not use it 8 times or 10 times or 12 times a day because from my experience, hyaluronate is a sink. It stays on the surface for a very long time. It has those tightly coiled long chain molecules which are able to trap everything in it, which is good and bad. Because in the most severe dry eyes, like I said, there's a lot of dirty stuff floating on the surface from the lids, and because the tears are not excreting the muck that's coming into the surface and so on. So this tends to hold on to those bad things. And when I use it 6, 8, 10 times a day in the initial period, I used to find a slight increase in inflammation in some of these patients. So if I feel I need hyaluronate, what I do is I use my carboxy CMC as my basic drug. They will use it 6 or 8 times. And I add the CMC 3 or 4 times a day, somewhere in between. So that helps with the epithelial healing. But it is not the only drug that they will use. I won't use it enough frequency for them to need the relief. The third one that I will use is something with a mucomimetic property. That is one of these HP guar based drops. So if I find a BUT problem, if I find tears are not retaining on the surface enough, then a guar based drop is used because it's a mucomimetic, because we don't have diclofenac yet. Once Santin brings diclofenac in, then that may become a better agent because that actually is a mucus promoter. It produces more mucus. We did have something, the rebamipide, 1 or 2 versions of it. They're very hard to find now, but they were not that effective for some reason or the other. But diclofenac is very effective. So once that comes in, maybe that can be the mucomimetic. So these are the 3 agents that I use, the HP guar, the hyaluronate, and the CMC, and this is my rationale. And if somebody has very bad ocular surface disease, then I would move to a CMC-based drop, but it will be unpreserved. So we do have 1 or 2 brands of those available. They're more expensive. So I retain them for the worst kinds of ocular surface disease. So I don't know if that answers your question, Sai, but this is my rationale for using the drops that are currently available.
Thank you. Thank you. Vinay, Prashobh, Anil, any questions for SKR sir? David?
Hello. So when do you use ointments? Do you use it routinely? Or?
Gopal, please mute yourself. Yeah.
So basically, as far as the ointments are concerned, we use them at night because the drops, no matter which one you use, they will go away after 15 or 20 minutes. So if you need somebody with a significant dry eye, we need them to have some comfort because they often wake up at about 1 o'clock or 12 o'clock to use the restroom or something. And then if they're very dry, they find it very difficult to get going. So the ointment often forms a protective film for them. If somebody has even more significant dryness, and these are basically the pathological kinds like the Stevens-Johnson and so on and so forth, then you can use an ointment once, twice, or thrice during the day as well for prolonged coverage and relief from the symptoms that they have. But ointments, by and large, blur vision considerably. So in somebody with good vision and mild to moderate symptoms, they don't form part of the daytime protocol. They get added on at night.
Okay. So if there are no more questions for SKR sir, Vinay, can we move on to the next case presentation?
Yes, sir.
Yeah. Is it Dr. Ramya?
Yes, sir.
Yeah, you can share your screen.
Okay, sir. Good evening. Thank you, Vinay and Cochin Ophthalmic Club for giving me this opportunity. I'll be presenting a case of 20-year-old male who presented to our hospital with a diagnosis of keratoconus. He was referred here for further management. He had no other comorbidities. On examination, unaided vision in his right eye was 6.9 N6 and left eye was 7.5 N6. And retinoscopy revealed a scissoring reflex in both eyes. And in the right eye, there was minus 1.50 diopter cylinder at 10, and in the left eye revealed a minus 1 diopter cylinder at 150. He was accepting a power of minus 1.5 diopter cylinder at 10 in the right eye and minus 0.75 diopter cylinder at 150 in the left eye. His vision improved to 6 and 6 in both eyes with correction. On examination, the anterior segment examination revealed a faint flacious ring in the right eye. So he was advised to undergo oculizer in both eyes. As we can see in the oculizer picture of the right eye, there is an inferior steepening associated with the corresponding thinning in the pachymetry map and also increased values in the anterior and posterior elevation maps. In the left eye also we can see that there is an area of inferior steepening with corresponding thinning and increased values in the anterior and posterior elevation map. So the diagnosis of keratoconus in both eyes was confirmed. And according to our hospital protocol, he was kept under follow-up and he was advised to review after 6 months. And the follow-up visit after 6 months, the oculizer was done again. This is the oculizer done after 6 months, the second visit, and this is the oculizer picture of the anterior sagittal map done in the first visit. We can see the difference between the two in this picture. There's significant difference of almost 1.1 diopters. And so progression was confirmed. So the person was advised to undergo the procedure, transepithelial phototherapeutic keratectomy with C3R. TPTK was done with excimer laser with 15 micron ablation, 6.5 millimeter optical zone, and ablation zone of 8.3 millimeters. And C3R was done according to the accelerated protocol with 0.1% riboflavin in HPMC instilled every 2 minutes for almost 20 minutes, and following which UVA was given for 90 milliwatts per centimeter square for 10 minutes, giving an energy of 5.4 joules per centimeter square. After the procedure, BCL was put, and he was put on post-op regime, moxifloxacin eye drops 6 times per day, notiprenolol eye drops 4 times per day, and a tear substitute. Post-operative day 1 was uneventful. There was small defect with stromal haze plus. So he was advised to continue the post-op medications and was advised to review after 2 days. But he came the second post-operative day with drop in vision and also symptoms like pain and discharge from that eye. And on examination, there was multifocal infiltrate present both superiorly and inferiorly with multiple infiltrates in between with lid edema and discharge. And AC was showing 3+ cells with fibrin. So a diagnosis of microbial keratitis was made. Corneal scraping was done, and it was sent for gram stain, KOH, and bacterial and fungal culture. Gram stain revealed numerous gram-positive positive cocci. And so he was started on fortified drops, fortified ceftazidime 5% half early, and fortified vancomycin 5% half early with atropine eye drops 3 times per day. On the next day, even though his symptoms improved much, he had pain was almost gone without, and discharge was very minimal, but the infiltrate size was shown to be increasing. So at this point, doxycycline 100 milligram twice daily was added. And the third day, we got the culture and sensitivity report, which showed that there was a growth of Staphylococcus aureus, which was resistant to fluoroquinones and penicillin. So the treatment was continued. And this is a picture in the first week. Even though the stromal infiltrate were reducing, there was edema and inflammation. So at this point, topical steroids was added, and Predford 1% 4 times per day was added. And he significantly improved. This is the 10-day picture with significant reduction in the infiltrate with scarring. By 2 weeks, inflammation almost subsided with scarring. This is the 2 months picture where the infective keratitis has completely subsided with a central corneal scar, thinning, and ectasia. At this point, his uncorrected visual acuity was counting fingers 2 meter N12, and his BCVA was 636 N12, accepting a power of -6 diopter cylinder at 40, and he was sent for RGP trial, and his vision improved to 6/9 N6 with RGP. Thank you.
Thank you, Ramya. Now,
Okay,
can you stop sharing this?
Yes, sir.
Yeah, yeah.
Now, quite a frightening case for many of us who would have, had to face such a thing. C3R is considered to be quite safe procedure. And what is interesting in this case is that, or rather in most of the, post cross-linking cases, at least the cases which I have seen, the corneal infiltrates in many of them are sterile. That is, I believe, is the commonest cause of, corneal infiltrates post C3R, probably, lid-related or contact lens related. Infective keratitis post C3R is not that common. And in most of them, it kind of have a devastating outcome. This case, actually the last 5 years, we have had 2 infections, and this is actually the second one. And actually, it is the experience with the first one which has helped us or in picking up the infection. Unfortunately, in the first case, when the patient called saying that he has some pain, irritation, it was just, the patient was told it is a part of the procedure and come on the 3rd day. And by the 3rd day, the patient came, there was practically a total corneal melt, which ended up in a therapeutic. So when this patient called saying he has a problem, we asked him to come immediately. And luckily, within 3 or 4 hours of his calling us, he landed up with a picture which he showed us. And at that point, we took a scraping, and the problem is we got the smears only the day after scraping, but we started him on intensive antibiotics. And in about 14 hours of starting antibiotics, the patient was symptomatically much relieved. Practically, the pain disappeared, the discharge reduced, but the infiltrate became really bad. As you could see in the second picture which you showed, it practically covered the entire central cornea. Well, luckily for us, it responded, it healed. And yes, there is a central scar. The uncorrected and spectacle corrected vision is drastically reduced, but at least with a contact lens, he has reasonably good vision, and for the time being, he's happy. And we'll see what we need to do later. But then there are a few questions which I have, to put across to the panel for, opinion. One is, as has been shown in many of the studies, it is a, common cell, staph or some of the other common cell, which is a common cause of infection. in post C3R infection. So what is the role of antibiotic prophylaxis prior to C3R in these cases? That is the first one. The second question which I have to put across is there a real difference in terms of infection between the standard Dresden protocol and accelerated cross-linking? Role of contact lens and immediate post-op steroids in infections, and in a routine case of C3R, how should we follow up? Should it be daily? Because first post-op day in this case was absolutely fine, and the second post-op day he came with an infection. So should the post-op be daily till the epithelium heals? So it's open for discussion. Opinion, please.
Basically, like you said, the staph, the picture that you're showing is not typical of a staph as far as I can tell. So maybe there was another bug that was missed, but because you had covered him with very powerful gram positive and negatives, he got better. But having said that, with the C3R, you basically destroyed most of the keratocytes in the cornea. So the ability of the cornea to respond to infection is also grossly reduced. And we've added steroids as well in the beginning, assuming that it's a normal case. So these can also enhance the virulence of an infection of an even otherwise less virulent agent. So for my protocol, I will tell you that, and the sterile infiltrates in any of these corneal procedures, to me, only when they happen in the periphery, I label them as sterile. Anything in the area of corneal intervention after PRK, LASIK, or CXL, if I see an infiltrate, to me it's infective until proven otherwise. We published a report of sterile infiltrates after PRK. This was donkey's years ago, 25 years ago, I think. But these infiltrates typically will occur inferiorly, close to the limbus with a lucid interval, but they will be multiple. Unlike the classical staph, which is one solitary oval lesion, which we see in lid margin disease, you'll see them multiple times. So that is a separate issue. So for me, if I see an infiltrate where I have meddled in the cornea, it is infective until proven otherwise. I will not treat it as sterile. My protocol basically is they do get antibiotics for 2 days prior to the cross-linking, just like I do for my cataracts. I use catifloxacin 6 times a day for 2 days prior. I do the accelerated protocol as well, but I use a 6-minute exposure time at 15. So it's the same 5.4, but we use 15 for 6 minutes. And we patch the patient. Early on, when I first came back from Hong Kong and I started practice here, a lot of people were using bandage lenses, and I'm sure you're doing it for all your patients as well. Nothing has happened. But in my initial cases, most of the CXL infections that were referred to me were people with bandage contact lenses. So in the Indian context, I do worry about sending a patient with a cornea that has been devitalized, in which a bandage contact lens has been put, and sending him to the outside with steroids on the eye. So our protocol is to patch the eye with an antibiotic ointment on the day of surgery. They go home with the patch. They come back the next day with the patch. We open the patch in the clinic. We have a look. We make sure that the epithelium is healing, that there is no infection. We repatch them again and we send them back. We call them back the next day. So basically, most people, 90% will heal in 48 hours with the second visit. In about 10%, they may need a third visit. And again, they will get patched and come back on the third day because these are sighted eyes. Often, like you said, 6'9", 6'6". So 3 visits is okay. I don't want to take any chances. And only after the epithelium is completely healed will we start our FML. I use fluorometholone. So the first 3 days when they're coming back for patching, we open the eye, we clean, we dress, we put some antibiotic, we put an ointment, we patch, and they go back. So we don't put topical steroids on the eye until they're completely healed. And touch wood, so far, we have not had any infections in our personal practice so far. This must be over 750 cross-linkings that we've done. So I've seen no reason to change this protocol. So, and I don't think there's any great difference between the accelerated and the regular version. If anything, in my opinion, the accelerated is better because there's less exposure time, even in the theater with the eye open. With the Dresden protocol, it takes 50 minutes to an hour. With this, you're often done in 30 minutes or so. So I think that exposure is minimized. So if you can patch the eye after you've done everything in your sterile theater without any problems, close the eye, and then, of course, I'm sure we look at the lid margin before we take them up for cross-linking. If they have bad lids, we treat that first and then take them up. So this is my protocol. Let's see what David and the others are doing.
Yes.
Yeah. When I also don't patch. I stopped patching about 10 years ago. Sorry, I stopped using BCL about 10 years ago. I made the switch out like after having an infection, and the few infections I've had, I think 3 or 4, almost all happened in people who had BCL on. So that is what I do. And I think on the contact lens actually carries most staphylococci. I think a lot of studies have shown that the staphylococci population on the contact lens is about 8 times or so more than the normal population. Normal what you see in the ocular flora. So that is another reason why I patch the eye. So I patch the eye, as SKR sir told, I see the patient next day, and I tell him to continue patching for 3 days and see the patient after within 5 to 7 days. And I don't give steroids. And if at all I give steroids, I give it after the epithelium has healed completely. If there is some significant stromal haze, then I think of steroids. I don't know whether it's fully justified, but on a regular basis, most patients, I don't use steroids.
Right.
Regarding pre-op antibiotic, I don't, like the day before, just like cataract surgery patients, I use. Nothing more than that.
Okay.
Yeah,
Right.
I have a question. I still use bandage contact lenses. I had one infection, but there's a actual cause for it. Patient's sister had eczema in her hands. That was probably what she was the one putting the drops. So my question is this: we know that patching actually promotes bacterial proliferation. Isn't that more dangerous than a BCL with antibiotics on top?
No, but in a cornea which is devoid of keratocytes, I think patching is slightly more safer. We don't.
And also during the protocol of the actual process of cross-linking, we do use some antibiotic on the cornea. I use moxifloxacin. So every time they put a drop of the riboflavin, they will also a few minutes later put a drop of the moxifloxacin. So I've used antibiotics preoperatively. I've done the procedure in a sterile environment with a lid margin drape. And while I'm putting these drops, the antibiotic has been constantly irrigating the surface. And at the end of the procedure, an antibiotic ointment is used, and then we put a patch on. And then we bring the patient back the next day to see the patient. So in that context, I think if you've done everything in a clean environment in the theater, you're just maintaining that clean protocol till he comes back the next day with the patch. With the contact lens, I'm not saying that it's bad, I mean, in everybody's hand, but because like Anil said, my initial experience was not good, and these are sighted eyes, so I didn't want to take any chances at all. So when I put a lens on the eye, like he said, the lens serves as a nidus to collect muck from the surface. And this is an inflamed eye. We've kept it open for 30 minutes in an accelerated procedure. You've kept it open for 1 hour in a regular procedure. So the conjunctiva, despite everything you've done, has been drying. So it will produce mucus, it will produce some stuff. And then the lid, if it is not particularly healthy, may throw its own component in. And all of these stand a very high risk of getting trapped either on the lens or under the lens. And no matter you're able to put your drops and you're putting some antibiotics, that's the advantage of putting a BCL. I think it's a balance between the two. So if you're very unlucky and if the patient has a very high quantum of this infective element on the surface, then the antibiotic may be overcome and then this may happen. So that is my rationale for doing the patching.
And incidentally, in both the infections which I had, both grow staph epi, which was resistant to quinolones. So, so the question arises: in case we are using pre-op antibiotics, what should be the one? Should it be quinolones, or should we shift to the older bacteriostatic ones, which is more probably useful?
You could, but these are occasional instances, and most of these patients, while they are getting prepped, will get povidone iodine on the surface as well. We put a drop of anesthetic, and then they put a povidone drop in 5 minutes before I actually start the procedure. And then the draping process, which is a little challenging because these are done without any anesthetic. So basically, the patients are, if you spend some time and drape your lid margins, then so far that's not been a major concern. But if you're having a series of these patients and if you're very concerned, then I guess something like a chloramphenicol or something, or whatever your antibiotic sensitivity suggests, might be a good static agent to use in these patients preoperatively and maybe even intraoperatively. The reason we use the MOXIE intraoperatively is because it's unpreserved. So from that point of view, when you're putting it 8 to 10 times, it kind of makes sense not to use a preservative containing drop.
Right.
Is there any concern with the povidone pre-op for C3R?
In what context?
In C3R.
No.
You do not use it for
concerns-
LASIK and all that.
We use it for LASIK as well. I use it for LASIK as well. Yes.
Doesn't produce
Particularly,
any toxicity or anything?
No, we
basically you use a drop in 5 minutes before, and then before we start, we put the drops in, and then anyway we're flushing the surface thoroughly with each procedure. And particularly in these COVID times, it's very important to put it because it's been shown to inactivate the COVID virus as well. So if you're worried about any kind of aerosolization from the surface with any of these procedures, so it's just like a cataract. So as long as it's even if it's an intraocular procedure, as long as you washed it away. And in fact, in cataract surgery, I know basically in LV Prasad, Merle uses it, a very dilute version of the povidone. Every 1 minute, it's a protocol for them. While she's doing a cataract, they squirt the povidone, dilute povidone on the ocular surface while she's inside with the probe, and that's her protocol. So I don't see that. I don't think there's any worry about using it preoperatively in the CX.
And post-op also, they put a drop of povidone.
Before they send the patient away, yeah. That I think I would worry, because if your wound's not particularly tight and you're putting a full strength povidone in, and if some of it gets sucked in later on, I might worry about inflammation. But yeah, each to his own, I guess, whatever works for that.
Yeah, I think if you look at the numbers, the like MOXIE, the amount of resistance is very high. I think one of the studies that is done in Kerala from Comtrest, they just randomly looked at the conjunctival swab cultures, and they found that close to 50% are resistant to MOXIE. So I would suggest using GATI or something else. Chlorphenicol, in fact, in that study was seen to be the amount of resistance was very little. I think 5% or less than that.
correct. Yes.
So anything that you have not used for 4 or 5 years will work again well. Even gentamicin now has very good sensitivity to a lot of bugs because you've stopped using it for 10 years. And the only other point I'll make in that particular patient is, because if you hadn't shown me the cultures and all that, I would have first thought of pneumococcus. That kind of a multifocal thing, and then the rapid spread that it happens, I worry about pneumococcus. So particularly if it's a gram-positive coccus and if it's a diplococcus, basically pneumococcus, because that does not respond to ceftazidime. You need cephazolline for those bugs. So that is something that we will keep in mind, not in this particular case, but if you see diplococci, then basically do worry about a pneumococcal, because that will not respond either to the fluoroquinolones or to your regular cephalosporins unless you're using cephazolline.
Yeah, and also that lag period when I was showing, like after he started the antibiotic and then infiltrate started increasing and then only it started responding, which is quite commonly seen in these virulent organisms like Pseudomonas or pneumococci. There is always a lag period there.
Right.
Can we move on, Vinay, to the
yes, sir.
third
talk?
Yeah, Dr. Kushal Gaur. Can you share your screen, please? Yeah.
Yes. Good evening, everybody. I hope my screen is visible. I would like to thank Cochin Ophthalmic Club and my professors, Dr. Anil sir and Dr. Gopal, for giving me an opportunity to present today. My case is of a patient, a 56-year-old male, who has been visiting our ophthalmology OPD since 2015, with gradual painless decrease of vision in both eyes since 6 months. He also has a history of ulceration in the mouth and dysphagia since last 2 years, and he was a case of biopsy-proven pemphigus vulgaris diagnosed outside. He had come to our hospital for a second opinion when he saw blood in his urine as a side effect of endoxan, which was given to him. He's also a known case of type 2 diabetes mellitus and dyslipidemia. At presentation, patient was on tab methylprednisolone 12 mg once a day, tab azuran, and also on his oral hypoglycemics and statins for controlling his dyslipidemia. On general examination, patient was moderately built and well nourished. There was no pallid icterus, cyanosis, clubbing, or lymphadenopathy, and the systemic examination was within normal limits. His cutaneous examination showed that there was a single erosion over the chest, and multiple erosions were present over the buccal mucosa, gingiva, and palate, and which predominantly showed us a mucus type of pemphigus vulgaris. And there was a thick white plaque over the tongue which suggested of candidal infection. Nikolsky sign was present. It is a dermatological sign, and the positivity of the sign indicates severe activity of the disease. It is also believed that on treatment, when pemphigus starts subsiding, Nikolsky sign is the first sign to disappear. On ocular examination, his vision in the right eye was 36 improving to 6.9, and left eye was 660 improving to 624. His IOP was within normal limits. His anterior segment in the right eye, except a grade 1 nuclear sclerosis, rest of it was normal. And the left eye also, the anterior segment was normal, just that he also had a fleshy pterygium, nasal pterygium, extending about 2 to 2.5 millimeters to the center of the cornea. His dry eye workup was done. Tear breakup time was more than 8 seconds. Shermus was more than 10 millimeters at the end of 5 minutes. There were no punctal erosions. His keratometric reading in the left eye showed that he had a cylinder of about 5 owing to his cataract. Hence, we diagnosed him as both eyes cataract with a nasal pterygium in the left eye. We had advised him a pterygian excision once he was systemically stable. Patient was admitted under our dermatology department, and he was investigated detailedly. His blood investigations were within normal limits. His chest X-ray showed a hilar lymphadenopathy. Hence, pulmonary consultation was sought for to rule out tuberculosis. His sputum AFP and culture came normal. Since he also had some vesiculobullous lesions on the skin, serum IgG and IgM for HSV was sent, which was proven to be negative. His pre-op serology also was negative. The biopsy of the buccal mucosa, which was already done outside, was reassessed by our pathologist, and also a new biopsy was taken in our hospital, and which showed signs suggestive of pemphigus vulgaris. There was suprabasal suppression of the epithelial cells. There was also acanthotic cells, and also the characteristic row of tomb appearances, the tombstone appearances were seen, and the immunofluorescence showed a characteristic fishnet pattern, which strongly suggested pemphigus vulgaris. The plan from their side was to start the patient on pulse steroid, dexamethasone 100 mg for 3 days with cyclophosphamide 500 mg, and giving him Mesna on day 2. He was also given tafluconazole on alternate days and candid mouth pain to treat his oral candidiasis. He achieved good remission with this treatment, and when he had come back to us, we performed a pterygium excision, and post-surgery, his keratometric value showed that there was only a -1 cylinder. Now we advise the patient for a left eye cataract surgery. Post this, the dermatologist had tapered his systemic steroids to 10 mg once a day. Following that, there was recurrence of his systemic infection, systemic condition, and over the course of next 2 years, he was admitted about 18 times in our hospital, and he underwent 12 cycles of pulse therapy of steroids and cyclophosphamide. Post this, the lesions had subsided, but lesions were still present in the esophagus, vallicula, epiglottis, and the lesions extended up to the anal canal, so his entire mucosa was involved. Hence, a diagnosis of recalcitrant pemphigus was made. Now, the second line of management, that is a lymphoma protocol, for 4 doses of rituximab was given. And before giving rituximab, we measured his desmoglein 3 levels of antibodies, which was high, but post rituximab, the levels had become normal. And then the patient was maintained on tablet mycophenolate 500 mg twice a day and tab bisolone 20 mg and 10 mg on alternate days. It was noticed that on reducing his steroid to below 20 mg per day, there was remission of the symptoms, recurrence of the symptoms. Then when patient came back to our OPD, after remission of the symptoms, his anterior segment was normal, but his best corrected visual acuity in the left eye had dropped to 1/60, and anterior segment showed a dense cataract in the left eye. Hence, we planned for a cataract surgery. The dry eye workup before the surgery was normal, but unfortunately, patient developed UTI, which went into a pyelonephritis, and we again didn't see the patient for the next 6 months. 6 months later, the patient presented to us with discharge and redness, more in both the eyes, with the signs more in the left eye since 2 days. And since we already knew this patient was at dermatology follow-up, when we had called and spoken to the dermatologist, they told us that there was no flare-up of pemphigus. There was diffuse congestion and mucopurulent discharge. We treated the patient as a case of conjunctivitis with erythromycin eye ointment, and we reviewed him after 2 weeks. 2 weeks later, the patient symptomatic, subjectively said his symptoms had reduced, but on examination there was mild pseudotosis. There were no lid margin erosions. Conjunctival erosions were present on the upper tarsal conjunctiva, and there were about 2 to 3 plus papillae present. His IOP was within normal limits, and we started him on lotoprotenol eye drops 4 times a day and lubricant eye drops every 2 hours. 2 weeks later, the discharge had decreased, but the papillae was still same as before, and there were no erosion seen. We had just done a mebography to see how the status of the meibomian glands. The left eye, the meibomian glands were the mebography was more or less normal, but in the right eye, there was a few meibomian gland dropout. Hence, we again sent the patient to dermatology and rheumatology to see if there was any fresh activity, but the inflammatory markers were within normal limits. Hence, we hiked up his topical steroids to 1% per acetate eye drop 6 times a day. And we continued the ocular lubricants. On reviewing the patient, after 2 weeks, we found that patient had steroid response with a high IOP of 42 mm of Hg. Hence, we decided to rapidly taper and stop the steroids over the next few weeks. And we started the patient on tacrolimus eye ointment 2 times a day. And also patient was managed with anti-glaucoma medications for his raised IOP. 2 weeks later, since the steroids were stopped, the papillae were found, and the patient was on tacrolimus, patient's papillae increased in size. But on 6 weeks, after 6 weeks of using tacrolimus, symptoms had reduced, and there was about 70 to 75% improvement in the patient, and the papillae had the papillae had decreased. After 3 months of tacrolimus, the patient was continuing using tacrolimus for 3 months. There was again worsening of the symptoms. The papillae reappeared, and there was discharge and redness in the eyes again. And during this entire saga, the right eye completely remained unremarkable. Hence, the diagnosis of left eye pemphigus vulgaris with recalcitrant disease in the conjunctival mucosa was made, or the other possibility could be a giant papillary conjunctivitis. Regarding this question, the other management strategies that we had in mind was supratarsal injection of triamcinolone, but this was deferred because patient already was a steroid responder. We thought of injecting giving a dose of rituximab supratarsally, but then it would have been of no use because there were no depot preparations of rituximab, and hence it would be of no use when we injected supratarsally. The other option we thought was to do an excision biopsy of the papillae, send it for histopathology to again confirm our diagnosis. But a buccal mucosal graft transplant could not be done here because the mucosa was not in a state to be transplanted. And the last option we thought of was excision biopsy with cryotherapy. Thank you.
Interesting.
No, in this case, I think all along this dry eye workup was perfectly normal, except in one visit where he had the very small 2 conjunctival erosions, and which turned into papillae in the follow-up, and then it went on increasing in size. There was a brief response to tacrolimus, but did not persist beyond 3 months. So first 3 months, I thought he is responding. I knew it is a B-cell disease, but still I gave tacrolimus because I thought that helper T-cell activity and further production of immunoglobulin that may be arrested at least to some extent. So that's why I gave tacrolimus. But there was after a brief response, it stopped responding, and now like it's going on increasing, and we don't have any other options to offer him really at this point of time.
It's surprising that he had so much of oral steroids without a pressure rise, whereas a short course of topical steroids is significantly.
Yeah, that is true. Like within say 3 or 4 weeks, he had IOP spike. But all along, we have checked the IOP multiple times, and like every visit, they come after a IOP checkup. So we have never noted an increase in intraocular pressure.
It is theoretically possible that the meddling that was done with the pterygium surgery has precipitated this asymmetric flare-up of activity in the one eye given his underlying state. But I think it makes sense to do a biopsy of that papillae and see exactly what is happening, because it's very unusual for it to respond to this degree of control with tacrolimus in 3 months, and then for no reason at all again start to flare up, particularly when a systemic state apparently has reached some kind of quiescence. So I would think I would want to rule out an infection. Many of these dry eyes, in my experience, have some kind of a chronic fungal infection that goes on that we sometimes miss, because these eyes are so immunocompromised locally that they pick up a candida infection very easily. So I would want a microbiology to be done, making sure that we're looking for a fungal infection. I think a biopsy of the papillae would help to make sure we're not missing anything unusual, anything else apart from the pemphigus itself. And then if you basically have no other, if all of these turn out to be all right and we're still stuck looking for options, I think the best thing would be a cryo. And then once you have the papillae under control, inject them with mitomycin C subconjunctivally to see if you can reduce the fibroblastic changes that are going on there and the papillae forming. Because I think if you try and do an excision and a mucous membrane graft, we may end up burning ourselves. If you believe that the whole thing started with a conjunctival meddling, if you do an extensive resection and then try and put an MMG, unless you're going to immunosuppress them very heavily with steroids, I think it may have a problem. So a cryo should be all right, and then maybe you could just inject him with a little mitomycin C and a little bit of a steroid and cover his steroid response in the post-operative period while that's happening. I think that's the best you can offer him.
Anil, I have something to ask. So his finally the systemic disease got control with biologics, right? Rituximab.
It is not exactly controlled. So I think what we spoke to dermatologists multiple times, they said that they checked the the antibody, desmoglein antibody, that is desmoglein 3 antibody, which is suggestive of a mucoid variety of pemphigus, and they checked it before starting rituximab, and after 4 rounds, that is after lymphoma protocol, they found that the antibody levels are perfectly normal, but the disease activity was there. So that they believe is because of that. There is something called epitope spreading phenomenon, which is vaguely similar to molecular mimicry. So you have an epitope against which the antibodies are raised, but when the disease goes to some certain state, it is seen that certain other epitopes also become antigenic. Okay, so even though the antibody levels are perfectly under normal and they have almost reached the height of immunosuppression in this particular case, they are seeing that disease activity is there. Even the mucus disease, it is present. It is not in the way it was like initially when we saw his mucosa, like all along the oral cavity was looking yellow in color. But now it is a few lesions are there, but he is never symptom free. So there is activity definitely. But according to the rheumatologist and dermatologist, I think they have given somewhat good amount of immunosuppression, and they feel that they cannot go anything beyond at this point disease activity.
Have they explained that hilar lymphadenopathy?
Hilar lymphadenopathy, I think pulmo consultation was done, and I think they really thought of tuberculosis. That is true, but they. I think we are given steroids after that multiple times, and it has never flared up. That is one way of looking at it.
But is that adenopathy gone, or is it still there?
That I
don't know. That we have not checked. But there is an entity called paraneoplastic pemphigus as well, where you can get this. So let's not just caught up along. But I mean, it's not our domain at all. But I think it might be interesting to make sure that hilar adenopathy is adequately explained, or that it has cleared up, or that we have to make sure that it's incidental. I can't understand why that should be there if the tuberculosis is negative. Right. So make sure we're not missing something else and just focusing on the pemphigus.
Yeah, with full immunosuppressive disease still active, I think, as Sir mentioned, the first thing would be to do a biopsy to make sure that whatever is happening in the eye is really because of the pemphigus.
Yeah.
And then I don't know. I don't mind. Quite baffling what else to do.
Dr. Anil, what was he on at the time of this flaring up of the eye problem? The systemic immunosuppression?
No, he was always on mycophenolate, and I think while the eye problem happened, he had received 4 doses of rituximab also.
And there was no change in the...
And even steroids he was taking, actually. Steroids 20 and 10 he was taking.
And with rituximab, was there any fluctuation in the eye state?
That happened actually before the this one, eye problem came. So I wanted to have a tissue diagnosis by taking a biopsy, but he was not very keen on biopsy.
Yeah, I also think that in some intractable uveitis also, in which there is steroid response, probably the only way is to hike up the systemic immunosuppression. We are always thinking about local therapy, but I think there is only that much a local therapy can do. I think we should try to hike up the systemic immunosuppression, not necessarily steroids, maybe something else, add something like that.
Can this manipulation in the form of a pterygium excision alone explain this much of unilateral activity? I mean,
yeah, that is baffling to me. Actually, in fact, I was looking like in the follow-up visits. I was looking exactly at where I have taken the graft. But in that area, it's looking perfectly normal. The ocular surface is perfectly stable. But it's only in the papillae. It's only in the upper tarsus that the problem is there.
No, this can happen because I've had people on OCP in whom some vitrectomy has been done where they've done some very minimal manipulation at the sclerotomy sites. But if you then see the natural history of this disease in the next 2 or 3 years, you will find a gross asymmetry between the operated eye and the unoperated eye. So the operated eye often behaves in a very bad manner. If adequate precautions were not taken at the time of the surgery in terms of immunosuppressing, putting a lot of steroids, because sometimes you're not aware of it. We just do the surgery and then later on this disease starts to show up and you can have a gross asymmetry, although this is even worse than what I have seen, what Anil has shown. So that's about the only way you can explain, unless you have some kind of a local masquerade, which is not really part of the pemphigus. And that is the other thing that we now have to seriously consider. If they believe they've adequately immunosuppressed him and the disease in the eye is really going from pillar to post, leaps and bounds, then maybe we should think of other things as well. Rule it out at least.
Could some form of a lymphoma present like this?
Theoretically, yes. Because that was a paraneoplastic thing that I was asking about. Hodgkin's is known to present sometimes with hilar lymphadenopathy and all that. And you can have a paraneoplastic pemphigus going on side by side as well. So I think infection, any masquerade in the eye must be ruled out at this point. And once we are clear that these are not happening, then we can go back to focusing on managing the pemphigus on the lines of a pemphigus. So let's not miss something else, I think.
Okay. Sir, one thing regarding that, I have spoken to the dermatologist whether it is paraneoplastic. So I think there is some other antibody, I don't remember exactly. They found that only this glycosylglycine 3 is present in this particular
positive patient. Okay. Okay. So this is not, like I said, our domain at all. It's in their domain. As long as they are happy that they have thought about it and ruled it out, I think we will have to go with that only. So then all we can do is to try and get this guy to commit to a little biopsy there. And then we can be clear that yet it is the pemphigus which is flaring up. And then we can manage it account, whatever lines we think are appropriate.
Thank you so much. I think we have come to the end of the academic session. I request Gopal to propose the vote of thanks. And I also thank Allergan. I don't know if someone from Allergan is on Zoom or they are watching it on YouTube. So special thanks to Allergan for sponsoring this meeting. Over to Gopal.
Yeah, thank you very much. So it was again a very fruitful symposium. Thanks for joining us, SKR sir. It was an amazing algorithm that you showed us, and there are actually a lot of people who want that PDF. They have put it in the YouTube comments box, so you could send it to Sai, and so that we can give it. Yeah. So a lot of people want that. That's really amazing. And that was one single slide with a lot of information, power-packed slide, the slide of the day, I would say. Thank you very much, sir, for joining us today and enlightening us with usually the Ocular Surface Talk is the one that is sponsored very frequently by all the medical companies, especially with tier substitutes. And the moment people hear Ocular Surface, people don't come. But this has been like we have more than 300 hits now in YouTube. So that's really commendable because of your presence. Thank you very much. Vinay, Anil, and David, thank you very much mentoring our little stars. And thank you, Kushal and Ramya and Nina. Okay, thank you very much. And thanks to Microvision for sponsoring this.
Allergan.
Allergan. I'm sorry. That was a fatal error. Allergan for sponsoring this. So
as usual, meeting adjourned, fellowship dinner at your own homes.
Please, for 26, we have a public program. We will meet for that.
Yeah. We'll give you more details about the public program on 26th.
Right.
So thank you again. Good night.
Bye-bye.
Thank you, sir.
Good night. Thank you. Bye-bye.